we are recording this meeting. Please shoot me a message in the chat directly to me. I'll be facilitating and asking all the questions to our presenters today. That way we don't have to worry about people muting and unmuting. So welcome to the first part of our COVID-19 lecture series, the Lunch and Learn series. Today we're going to be focusing on emergency medicine. I'm happy to introduce our speakers today, starting with Dr. Lerner. Dr. Lerner has over 20 years experience in EMS research with a focus on acute injury care. She has a balance of formal training as an injury epidemiologist and 5 years of field EMS experience. Dr. Lerner has authored more than 135 peer-reviewed publications and has received and completed many federally funded grants to conduct EMS research. She currently chairs the Pediatric Emergency Care Applied Research Network and a national network of investigators who conduct pediatric-focused emergency medical research. Her main research contributions have been in field and disaster triage. She led the development of the current national guideline for mass casualty triage, and her research contributed to the current national field triage guidelines for trauma. She has significant experience working with local, regional, and national governmental and non-governmental agencies to assist in interpreting and translating EMS research into practice. Most recently, she worked with state stakeholders to get a dispatcher CPR law passed in Wisconsin. Her contributions to the field of EMS were recognized when she was chosen to receive the Keith Neely Award for the National Association of EMS Physicians, one of the highest honors in EMS. Moving on to our second amazing presenter today, we have Dr. Manka, who received his medical school degree from the University of Buffalo in 1996 and stayed in Buffalo to complete his residency in emergency medicine. Since 1999, he has been a faculty member in the Department of Emergency Medicine at UB and currently holds the position of vice chair. He has also been an attending physician in the emergency department at Erie County Medical Center, where he served as chief of emergency medicine since 2007. Dr. Manka has published in the fields of trauma care and emergency department operations. He is an oral board examiner for the American Board of Emergency Medicine and helps train emergency medicine residents completing their residency at UB. Dr. Manka has also served on numerous hospital and university committees and currently serves on the board of Mercy Flight and the Great Lakes Physicians Steering Committee. So I'll now hand it over to our speakers. Remember, if you have any questions, please send them to me directly. I've changed my name, so it should say Samantha Hidalgo. Alrighty, thank you so much.
Thank you for having us. Mike, do you want me to start?
Sure, Brooke, you go ahead.
Okay, let me see if I can share my screen. And great. Hopefully you can see my slides, correct?
Absolutely.
All right. So I'm just going to start out by telling us a little bit about the effect of the coronavirus from a national perspective on the EMS system. And I just want to acknowledge that this work was supported by funding from both the Health Resources and Services Administration as well as the National Highway Traffic Safety Administration. And none of what I'm going to say represents their official position or should be inferred as their endorsement. So as the effects of COVID-19 have evolved, it's really important to understand the pandemic's effects on our healthcare system and our population. So really early in the pandemic, efforts were made to decrease the virus's spread. And so as communities implemented social distancing interventions, they started to message the concept of reducing virus spread and decreasing the burden on the healthcare system. This message was explained in the popular media as an effort to flatten the curve, and the image shown here really began to appear widely. If anybody who uses social media, I'm sure has seen it. And the interesting thing is we started to see some new patterns emerge in access to care just in general, as well as things related to COVID-19. And so starting March 9th, which a lot of this lecture, I'll talk about the numbered weeks. So the first week of the year starts with January 1st, and then you kind of count your way through. So week 11 is March 9th, which is really where cases hadn't yet started to emerge. Nationally, there were 2.5 million emergency department visits. If we look at that more locally to the New Jersey, New York, and I'm not sure why, but Puerto Rico is kind of part of our region, there were 223,489 ED visits. And at that point, we had seen about 5 deaths in New York and New Jersey. But as we moved through to March 30th, or the 14th week of the year, nationally, ED visits dropped across the country to 1.2 million. And so you might think, well, that's because the virus wasn't as bad in some of the other states. But if we look again at our region, New York and New Jersey, they dropped from that 223,000 to 144,000. And at this point, there were 3,950 deaths in the New York, New Jersey region. So this is a really dramatic drop in the number of emergency department visits in general during that time point. And these same things we're seeing in other countries as well, where just the visits dropped in general. But then interestingly, anecdotally, emergency physicians and other medical providers reported that the actual patient visits had a higher acuity. And so people were showing up sicker than they normally would in the emergency department. And so our group was really curious to figure out if these similar effects that we were seeing in the national numbers for emergency department visits were also seen in emergency medical services providers. So were our ambulances seeing kind of the same effect? We knew that there were some anecdotal reports of a sharp increase in 911 calls for people who were in cardiac arrest. But there really were no reliable scientific reports like we could find if you went to the Johns Hopkins website, where you could see the numbers of COVID cases, or to the CDC's website where you could see the numbers of ED visits. So our team worked to kind of quickly identify what was happening with our EMS providers. And so luckily here in the United States, we have the National Emergency Medical Services Information System database. And so we call it NEMSIS for short. Basically, it's populated by the medical care records of many of the EMS agencies across the country. So in fact, 47 states and territories contribute to this in near real time. And so what happens is the National Highway Traffic Safety Administration puts out a set of data definitions. So that's that blue circle at the bottom. Each local EMS agency then chooses which of those data points they want to collect, and usually it's more than what's required by their state. So they collect that data and then they push it up to their state EMS office. The state EMS office collects the variables that they're interested in. Then they take a subset of those variables, and all the states contribute that to the national database. So the interesting thing about this is this happens electronically kind of no matter what. So the data doesn't really lag. So even in these high call volume times, high workload times, this data is still available. So it seemed like a really good source for us to look at. And so we looked across 3 periods, looking at starting the 40th week in the year 2016, 2017, then in the year 2018, 2019, and then finally in the year, which is shown in red here, 2019 to 2020. And so again, one of the interesting things about this, it's an evolving database. So in 2017, there were 32 states contributing data. In 2019, it's 40. And then in that red line, it's 44 states. So that's one of the reasons you see such a difference in the volumes, is that there's many more states contributing data in that 2019-2020 year. But what we were really focused on is this area in blue. So this is the 10th week of 2020, which began March 2nd, through the 16th week, which would have been April 19th. What we see is across the country, 140,000 drop in call volume, or 26% decrease in call volume. So with fewer states contributing, we had less call volume than we'd had the year before. And we don't really see any pattern like that in the other years. They all are kind of consistently following a pattern. You'll notice that bump in week 1, and that has to do with states passing mandates to contribute data. And so you see a big jump from December to January, where people are making sure they meet those mandates. The other thing we looked at was this idea of higher acuity. And so we focused on people who were identified as being dead or in cardiac arrest when EMS arrived. And so again, what we see in that same time frame is a doubling of the percent of calls that were related to cardiac arrests. So represents about 2,000 more people experiencing cardiac arrest than normal. And so you can see that maybe that's going to taper off. It's a little hard to know what happens past that week 20 and 21. Some of that may be lagging data, but you know, it's still quite high. The other interesting thing is to think about, you know, if everybody went home, our behavior patterns would change. And so what happens with just normal injury calls? And what we see is a big decrease in injury calls as we first went home, so that March to April period. And then as people started to figure out how to resume some of those activities, we see injury kind of coming back to what it had been prior to that period. So why do we care about this? Well, first of all, it's very interesting to think about the public health implications and what the behavior changes were that led to this steep decrease in call volume and perhaps an increase in acuity. And so we saw similar things with coronary syndromes, that people were coming for care for those at a lower rate in both the United States, Spain, and Australia. And so there was a study that was published where they asked people why they delayed their care for a myocardial infarction. And a third of them said that they were either afraid to access care or that they didn't want to burden the healthcare system. So the thing about this is our findings are positive if people who don't need the resources are staying home, right? If what we're talking about with, you know, not burdening the healthcare system is getting people who can delay care to delay that care or find other sources, that's probably positive. Unfortunately, it's concerning to see the increase in deaths and the increase in acuity. You know, we saw a doubling of deaths not related to COVID in both the United States and Italy. So that seems to indicate maybe people aren't getting care who might need it. We also saw it in Portugal, where there were excess deaths not related to COVID-19. The other thing we need to think about is there are implications for our EMS systems providers. So these high acuity patients can be more stressful, especially if they experience negative outcomes that might have been avoided with more timely care. And so this can result in some long-term negative consequences for them, both in terms of health and well-being and longevity in their careers. The other the other concern that we have is about the economic impact of this. So, you know, EMS agencies need to schedule their ambulances, so there's always capacity. If all their units are responding at the same time, then there's no capacity for that next person that calls 911. However, if there's too many units that are waiting for calls, then that's a higher cost to maintain that system. And in fact, most EMS agencies only earn revenue when they treat and transport patients. So there's not really, you know, having people waiting for calls can have negative consequences. The other thing is the way that EMS systems are created within communities is they frequently require a certain number of units to meet response time requirements. So you have to have people scattered across the community so that everybody in the community has access to care in a certain amount of time. So this drop in call volume that we're seeing is translating into some real financial issues, because the cost to maintain these systems is flat to be able to give those same response times, while the actual revenues from treating and transporting patients decline. So this has led to some significant budgetary shortfalls to agencies across the country that may be difficult to recover from as we move forward and move out of the pandemic. So I think as we think about how we're maybe going, you know, we're clearly increasing the number of COVID cases that we have in our communities, and we're about to message these things again about and continue to message, trying to flatten the curve, really thinking about how we ensure that people still access care when they have emergent situations is going to be really important as we go into this second increase in cases that we're seeing right now. So we can maybe go over the conclusions after. I'll turn it over to Mike to share about the emergency department's direct implications.
Thanks, Brooke. I'll just pull up my presentation here. That's the end of it. Let's go back to the beginning. Okay, so that was a lot of what you talked about related to EMS is really translates almost exactly to what happened in the emergency department. So I thought I would just talk a little bit about kind of the effect of the pandemic on local emergency departments, but really what happened locally happened pretty much everywhere around the country from talking to our colleagues and listening to our colleagues elsewhere. And I'll also share the perspective of being the director and chair of our department here, chief of our department here at ECMC, and kind of some of the challenges that it posed from a leadership standpoint, trying to lead our team through the initial phases of the pandemic. So I liken the pandemic to a kind of a slow mass casualty incident. And in emergency medicine, we are, one of the big topics that we talk about, and particularly over the past decade, has been managing mass casualty incidents. As we've seen increasing mass casualty incidents around the country and around the world, we all have put a lot of effort in being prepared for any of those type of events. A typical mass casualty incident will occur where there's a single event that occurs, whether it's an act of terrorism or a weather-related event or a biologic event or something to that effect. It's usually an acute event that happens where you have very little time to prepare for it, and you have very little information about what happens or what's happening out there. The pandemic was quite different in that you actually had a fair amount of time to prepare for it because it was happening around the world before it hit the United States, and even happening in other places in the United States before it hit our local community. So we had a lot more information from colleagues working elsewhere, even colleagues working in our state in New York City, about what was happening and kind of what our expectations should be. In most mass casualties, there's a first and second wave that occurs. And the first wave in many mass casualties are victims who are kind of the walking well, who can make it to the hospital on their own by private vehicles quickly. And then the second wave, interestingly, is often the more seriously injured victims who can't leave the scene immediately because they're severely injured and arrive at the hospital by EMS. So the ambulances that bring patients from, let's say, a mass shooting event are often arriving after patients that arrive by private vehicle who are less severely injured. And this event was somewhat similar to that in that we started seeing patients early with symptoms of a bad viral illness and with symptoms of some viral pneumonia, but we really weren't seeing the sickest of the group, the patients who are going to require hospitalization, until we were into it a couple of weeks. We talked early on about setting up triage tents, like in this picture here, to kind of manage a large influx of patients presenting with mild symptoms. And the idea with that, this is really something that happens in all mass casualty incidents. The idea with that being that you want to keep patients out of the emergency department if it's becoming overcrowded, and you want to keep patients who are...
Hey, Mike, I think you're not sharing.
Okay, let me try that again. Thanks for letting me know. Okay, let's go back. Luckily, you didn't miss much. I'm still on the second slide.
If you have trouble sharing content, let me know, but I should have given you both the ability to share.
See it now?
Yes, you're good.
Okay, so you didn't lose much. So the triage tents that I mentioned we had planned on setting those up early on in the pandemic, and we got them all ready to go, had them set up, and interestingly never had to use them because we didn't really see the numbers of patients locally that places like New York City were seeing. Command centers are always set up during a mass casualty incident to deal with kind of the control of information, both coming in and going out, and for everyone to have a place to refer to kind of know what's going on. And that was set up early on in the pandemic, even before it hit locally. And then kind of common things that occurred during a mass casualty are staff fatigue with a large influx of patients arriving. Oftentimes in the more dramatic mass casualty incidents, like in mass shootings, staff will end up staying, working doubles, triples, just being extremely fatigued by the end of the event because they've stayed at the hospital and have worked through the entire event. And that's really not possible in this type of event because it's a much more prolonged, slow mass casualty event. But we still see some of the same effects of staff fatigue with dealing with these same issues of the pandemic and patients with possible COVID coming in on a regular basis. I will say that the whole pandemic, the way it's affected hospitals around the country is that it's had a much harder impact on the intensive care units. The emergency departments have been able to manage fairly well. The intensive care units have been overwhelmed because their resources are often much more limited. So those patients that come through the emergency department may spend a few hours in the emergency department before they go to the ICU, and then they may spend months in a bed in the ICU, which leads to the ICUs filling up and being really overcrowded. So this graph just shows kind of what happened at ECMC, and you can see that the green number, the green color there is the total number of COVID patients in the hospital. And we peaked at about 47 COVID patients at ECMC. Our ICU is the purple curve there, you can see here. And that kind of followed the initial wave of sick patients that were requiring hospitalization. And then, of course, the deaths, which is the yellow curve, follows both of those curves. There's that delay until those patients either, survive and are discharged or pass away. And after that initial wave, Brooke talked about flattening the curve, and we all did a great job with social distancing and wearing masks. And you can see that those numbers, especially during the summer, really dropped low. And then, of course, the fall hit, and we've started to see an uptick. And unfortunately, this slide ends at the first week of November. And if I had the data for the last 2 weeks here, you would see the curve going straight upwards in terms of both the number of hospitalizations, the number of patients who are positive. And thankfully, up to now, we have not seen quite as sharp of an increase in the number of patients requiring ICU care and being on ventilators. This is, again, kind of the same idea that Brooke talked about with EMS activations, in that after the pandemic started, this shows our visits to our emergency department last year in blue, and then this year in the orange color. And the blue color there last year is kind of the same pattern we have every year. We're somewhat seasonal in our volume, in that our summer months are the busiest, being a trauma center. We have a lot more trauma cases in the summer. So we always have a spike a little spike in June, July, August. What happened was after February, the first cases that hit Western New York were in mid-March, and we saw our number of patients coming in plummet down to just over 100 patients per day. This is total patients, not COVID patients. Total patients coming to our emergency department plummeted in April. And then since April, we've gradually crept back up, and we actually have reached kind of the same number of patients arriving now since the end of summer that we had last year. If you look at what's happened both nationally and locally in most emergency departments, you would have seen that number still about 10% less than last year, even up till this point in the year. And at ECMC, we feel that we kind of came back to normal volume because of a couple of reasons. One is because the summer trauma season was quite busy. And also because many of you probably realize we just opened a brand new emergency department at ECMC, and that that was well advertised, and that got enough attention and buzz that more patients were coming to our department than to other local emergency departments. So that drop in patient visits really presented some of the same staffing challenges for us as it does for EMS. And one of them is trying to match your staffing to your needs from a patient perspective. So the emergency department has to be staffed, fully staffed, pretty much 24/7. I mean, you never know when you're going to get an influx of patients. So you have some variation throughout the day with your overnight shift being a little bit less staffed, but you always have to have providers and nurses and techs and support staff staffing the emergency department. During the early peak, when we saw our volume really dropping, it was kind of an interesting phenomenon where we were seeing some really sick patients, but overall we did not feel busy at all in the emergency department. And we were sending staff home on a regular basis early, or telling staff not to come in. And we reduced our staffing by about 20% during those early months. We also started screening all employees coming into the hospital with temperature checks at every point of access into the hospital. And we sent home, we didn't have our ancillary staff come in that didn't need to be there. So our research associates, our students, that staff was really told to stay home to prevent them from getting sick by being exposed to COVID patients. Another unique thing from a staffing perspective was that providers in general have a mindset that they should come to work no matter how they feel. So the physicians and the PAs and the NPs who work in emergency medicine very, very rarely will call in sick, even when they're actually quite sick. We've had some of our team of providers have worked shifts through, bad cases of the flu with high fevers. And there's just kind of this mentality that they have to be there to take care of patients, and that to call in sick is almost a sign of weakness for them. And it requires us calling someone else in from home. So we really don't do that under normal circumstances. Of course, with the pandemic and knowing that anybody who had flu-like illness could have COVID, we really encouraged our staff to stay home if they had any signs of flu-like illness coming on. So even if someone just had, a runny nose or a sore throat, they were now told, like, don't come in, stay home, and we'll figure out a way to cover your shift. And then, of course, we had to develop guidelines for them in terms of how to return to work, which was difficult because testing early on was very limited. And so people were faced with the situation where if they even had what seemed like a minor cold, they were told not to come into work, sometimes for up to 2 weeks to quarantine. And then the last part of the staffing challenge was really developing an on-call schedule, which is something that most emergency providers are not used to being on call. It's one of the unique things about our specialty is that we work shift work, and when we're working, we work very hard, but when we're home, we're typically never called into the hospital. Well, this pandemic has changed that, where we always have to have someone on backup to come in case one of our colleagues is sick with even a minor illness. So I just want to say a couple of words about PPE. This was really an interesting phenomenon. Early on in the pandemic, the reports coming out were that face masks really weren't necessary for the general population, and that they may not even really help for the general population. And the same thoughts were true in the hospital early on, where nurses, doctors throughout the hospital, and even in the emergency department, were not wearing masks routinely unless they were going into a room to see a patient with symptoms of possible COVID. And then the transition occurred where people realized, well, we should probably wear a mask all the time because it seems like some patients are asymptomatic. And it progressed very rapidly from very little mask wearing to everybody wearing a regular surgical mask, to everybody wearing a high level N95 mask, or one of these PAPR suits, hoods that you see in this picture here. And we were all faced with this challenge, all the hospitals, of trying to secure enough PPE to have an adequate supply, as we were going through it very rapidly by using it every day. And some of our providers even went as far as ordering their own face masks, like this gas mask type mask there, to bring into the hospital in case the hospital ran out. And that was challenging to manage from a standpoint of who was going to bring in what equipment and who was going to show up to work with what type of equipment on. We had some providers who would come into work wearing a full body suit, such as the picture here, and then other providers coming in with just a surgical mask. And so it was very difficult to present a kind of a united approach to PPE at the beginning. We also had some interesting phenomenons occur with equipment. This whole pandemic has kind of brought out the MacGyver in all of us. And early on, people realized that intubating sick patients with COVID was probably the highest risk procedure we could do, because our faces are right in the face of a patient who we're going to be inserting a breathing tube into their airway. So, and we knew from reports around the country that emergency physicians were occasionally getting really sick when they were infected by patients, and they were probably infected when they were intubating patients. So some of our team of providers actually made some homemade intubation shields, like this picture up in the top, where they had essentially just plastic draping that they got from Home Depot, and they would drape it over something that could then provide a barrier between their face and the patient's face. And then we started having commercial products like this picture down the bottom. It's a plexiglass type box that you can put your hands through, and it just provides some protection by another barrier between your face and the patient's face. There's also a change where any patient that was put on a ventilator, now we had a viral filter that we had to put in the circuit so that we were preventing the virus from circulating through the room. And face shields became a common approach to taking care of these patients as well, from a PPE standpoint. And we actually had a ton of donations of these face masks from different companies who maybe had them for other uses. We actually had some of the schools, local schools, donated their supply. We had actually Jack Eichel, the Sabres player, donated a bunch of face masks that from the company Bauer, who is one of his sponsors. And it was really, heartening to have the community really step up early on to help the frontline workers. One of the effects of all these challenges was that the supply chain for standard equipment was really being challenged. And we were able to get some of this PPE, but then we were having challenges with securing our day-to-day equipment that we used for other purposes. And this picture of this person pulling their hair out is kind of how I felt during the early phases of the pandemic, because every day I was sending out updates to everybody in our group and all the providers just to keep them in the loop of what was happening. And early on, the protocols for testing and for cohorting our patients in one zone and for visitation by loved ones and therapeutics of what we were using to treat people with COVID, those were changing on a daily basis early on as we were kind of learning more about the disease and learning what seemed to make the most sense for our institution. I will say that it really brought out some challenges trying to deal with conflicting opinions, because as professionals in healthcare, we all have ideas about what's the right thing to do. And when it came to some of the decisions about therapeutics, the evidence was very slim. You all remember the hydroxychloroquine discussion that occurred with the president really promoting it. And then half of our group wanted to give it to all patients. The other half thought there's not enough evidence. So developing guidelines early on was really challenging. I'm sure that all of you has had some challenges, either being tested yourself or trying to arrange testing for somebody. We had challenges in the hospital early on as well. We initially were only able to test patients through the county health department's lab, and they had a very limited number of test kits available. So the guidelines for who we could even test was very strict. And that was interesting. It actually led to a lot of frustrated patients who came in expecting to be tested. And we had to tell them that, unfortunately, we just didn't have the testing supplies to perform the test. Early on, the test results were taking up to a week to get the results back to patients. And then within the first month, we were able to start testing people using our own hospital lab. And then subsequent to that, a few months later, we're able to start instituting rapid testing so that we could identify patients while they were still in the emergency department, particularly the ones that were really sick. And we thought for sure they had COVID. We had a test available then to kind of tell us yes or no within the first hour. One of the challenges for our hospital and for all hospitals has been securing enough testing supplies and reagents to be able to have enough tests to test all the patients coming in, and that continues to be a challenge. Hospital operations have really changed during this pandemic. The hospital, particularly for its COVID floor, where we're cohorting all of our patients, switched from semi-private rooms to private rooms. So many of our hospital rooms, unbelievable to me that this still is the way it is, but many of the hospital rooms have 2 patients per room with just a curtain in between. Well, with COVID, you really can't do that. You want to have patients in private rooms so that they're not affecting the other patient in the room. So that has led to a real challenge in terms of hospital capacity, because even though we may have the same number of rooms, we've actually decreased our capacity by making them all private rooms. The hospital, as I mentioned before, had changes in their visitation policy to the point where there was no visitation allowed. And that was challenging for us in the emergency department as well, as we see a lot of patients who, have some cognitive problems, whether it's dementia or something else, and not having visitors present, loved ones present with them was really challenging to try to take care of patients and obtain histories. Elective surgeries were canceled in the early phase of the pandemic to allow for more capacity in the hospital, to try not to have elective cases coming in and occupying patient rooms. And then our medical ICU was converted to only COVID patients. So, of course, there's still many other sick patients coming into the hospital, and trying to find places to take care of them was challenging. Our trauma intensive care unit was able to flex up a bit and actually take care of many of our medical patients who didn't have COVID. But this led to challenges for our institution because as a tertiary care center, we received many transfers from other outlying hospitals. And that's all predicated on the availability of hospital beds and places to take care of patients. And the COVID pandemic really, because of the changes in the hospital, forced us to rethink which patients we could accept and which patients we had to tell other institutions that they would have to manage at their institution. And similar to EMS, the financial challenges have been huge, particularly for the hospital, because as the numbers of patients dropped during the pandemic, the hospital relies on having a high volume of patients to meet their financial needs and to keep their budgets neutral. So all hospitals in the region saw a huge hit to their budgets, and all hospitals have gone into the red for this year. So what do we do in the emergency department to keep our patients and staff safe? We did a few things. We cohorted our symptomatic patients into one zone so that we could keep patients without symptoms separate from those patients. Our environmental services team went to high-level cleaning protocols for all the rooms, and early on there was a lot of concern that the virus could be spread over surfaces, and luckily that has been shown to have been not really the case. But wiping down every surface in the room before a new patient was put in was instituted. We embraced technology and started communicating with patients even while they were in our department. We would call them by phone from outside the room to get a history from them before we actually went in to see them. We used iPads to connect with patients within the department, and we expanded our use of telehealth to interact with patients remotely. I mentioned a little bit about some of the things we did with intubations to try and add a layer of protection to our staff. We stopped using medications via like a nebulizer treatment, a respiratory treatment that can have a lot of the aerosol spread throughout the room, and switched to using these inhalers, like the picture here in the bottom right side there, which are much less aerosolizing. So that hopefully if a patient has COVID, and they need a respiratory treatment, they're not spreading it as actively throughout the room. And one of the positive things we identified after a couple of months was that we found that our staff really was not catching COVID even at the same rate as the community was catching it. So that made us realize that using good PPE was very effective at preventing healthcare workers from contracting the disease from their patients. I mentioned telehealth. The hospital partnered with us to create a platform for patients to have virtual emergency department visits. And so patients could actually schedule a visit by visiting the ECMC website, and one of our emergency physicians would see them over the computer over like a Zoom meeting to provide care that way. Just wanted to mention kind of some of the personal effects on the staff. This has affected everybody a little bit differently. Many of our staff, especially early on, was faced with a lot of stress and a lot of anxiety about, particularly about their exposure to patients with COVID and what that would mean to them catching it or bringing it home to their family. And you heard stories from around the country of people actually setting up tents, emergency physicians setting up tents or nurses setting up tents outside so that they don't have to go in and possibly spread the virus to their families. I don't think any of our providers did that, but certainly it was concern. I know that many of our providers changed the way that they, when they get home, how, they weren't walking right into the house with their clothes on from work. Many of them were actually getting changed in their garage, stripping down out of their clothes, changing into some other clothes, and then going right to the shower as soon as they got home so that they didn't spread it to their family. And early on, many of us were faced with a situation that our family and friends, even when people were starting to visit each other during the summer months, many of our family and friends were hesitant to get together with us, even outside and distant from social distancing, because they felt that we were higher risk because we work in the emergency department. And we had to reassure them that our rates of contracting COVID were actually less than the overall population. So we really weren't at any higher risk of spreading it than anybody else. Just the last thing I wanted to mention related to one of the unique phenomenons of the pandemic, particularly here at ECMC. This is data that shows our major trauma cases for the year, year to date. And if you look at the orange bars for this year, you see that patients who fall from a height, which is actually our most common cause of trauma, particularly in elderly people, those numbers are down some from last year. Our motor vehicle collisions are down. Our motorcycle crashes are down. Those are probably a reflection of less people being out on the roads, particularly early on in the pandemic. But what we've seen is our violent trauma, our penetrating trauma, like gunshot wounds, stabbings, and assaults have all gone up because of the pandemic. Gunshot wounds especially. And this has been a national trend. The causes for it are, pretty complex and mostly social issues, but we have seen what everyone else around the country has seen, which is a huge spike in gunshot wounds and in violent crime, or violent trauma rather. So kind of in conclusion, the overall impact on our emergency department and similar to local emergency departments has been that there have been, many operational changes that we've all kind of gotten used to. A decrease in the number of patients that are coming in seeking emergency care. We also are seeing the higher acuity of patients that's been reflected by an increased admission rate, similar to what Brooke mentioned related to EMS activations. And then when you think about changes in the workforce and the future of emergency medicine after the pandemic, I think that during the pandemic, you're seeing the workforce contract slightly, and we're noticing that with our graduating residents and that there's a kind of a glut of providers out there looking for jobs right now. But I think that the future after the pandemic is my feeling is that it's going to go exactly back to where we were before, which is that emergency department visits around the country continue to rise year after year. And that's really related to the healthcare system and some of the gaps in care for particularly the under or uninsured patient population that we all serve. Okay, that was a lot of information, and I went through it pretty quickly, but I want to save a little time for questions. I just want to say thank you for, letting us present to you guys about what's going on in emergency medicine, both locally and nationally. And just a plug for our brand new emergency department. This is a picture of the outside of it. And hopefully none of you will have to come as a patient, but certainly if anybody wants to come visit when the pandemic is over, I'd be happy to give you a tour.
Thank you very much, both of our presenters. Those were very informative presentations. I'm currently a public health student, and I felt like I can apply a lot of what both of you said to my future career endeavors. So I know you guys, we have a few minutes left. I have a couple of questions that people submitted prior or during their registration. So either one of you are open to answer. Our first question is for students, I'm assuming medical students, how will training change during COVID, and how can I get exposure in emergency medicine during COVID as a preclinical medical student?
Yeah, that's a great question. We have positions that we fill. Like Mike said, we have research assistants who work in the emergency department. And with COVID, we had to basically put an end to that program, although we are starting to bring it back as we focus on some COVID related research. But for sure, I think we're finding kind of new ways to interact and new ways to teach. I think we still see, I think we see people being a lot more conscious of things where people don't really need to come in, and offering that training over Zoom and doing those sorts of things. So I think it'll be really interesting to see what we keep when this is, passed. And how much I think medicine will go back to what it was, but for sure I think training and those interactions with people might change to be kind of a different model more often.
Yeah, medical students are back doing their clinical rotations in the hospitals, which is, a good thing for their education. And I think the challenge is people who are looking to shadow or looking to just get some exposure to emergency medicine or medicine in general. I know that providers, not just in emergency medicine, but in other specialties as well, are really limiting the ability of people to just come in and shadow to try and, prevent people from being at the hospital unnecessarily. So hopefully, I'm an optimist at heart. I'm hopeful that by the spring, things will have taken a turn in the right direction as we see the vaccines coming out.
That's my hope too. Another question that we have, and Dr. Lerner kind of talked about this a little bit, but what kind of research initiatives in the ER setting are currently being done during COVID? I guess that question is kind of broad, and you can kind of tackle it a bunch of different ways.
Yeah, so from at least a UB perspective, we really put a priority on engaging in COVID research. And so like all our regulatory processes and things like that really work to implement those programs as quickly as possible. So we've seen a kind of broad range of both industry sponsored and individual research investigator initiated research around treatments, prognostic testing, and various things that are being done in the emergency department. I think similar to the sort of ingenuity that we're seeing with how to teach under these circumstances, we're seeing the same thing with research. So we've really, seen some changes in the process for like consent, where we're trying to make sure we're limiting, people's interaction with each other. So we're actually about to start next week a project that'll use phone consents in the emergency department, in that, nobody should be with someone who's suspected of having COVID for extra time. And so what we'll do is call them their room and talk to them kind of through the phone. So there are projects still going. This is a weird time to have this conversation. We had just started to kind of ramp back up for research not related to COVID. It'll be interesting to see in the coming days kind of where we end up with the changing of the designation for our area. But we're pretty conscious of trying to still move science forward while still protecting everybody and keeping those research endeavors moving forward, because we still need that science.
I know in my own experience, I'm also a research assistant over at Roswell, and the ways in which we've had to adapt in our human subjects research has definitely been interesting. And now that there's the potentiation of going into a second lockdown, it's like we just got here now. We're going to have to go back to thinking creatively on how to get certain things done and potentially even moving our research to being remote. So moving another question, are thresholds for ventilator use on COVID-19 patients higher now compared to spring 2020? And if so, why?
So we've learned some things that have made us approach the patients slightly differently related to ventilators. Um, Early on, many hospitals were very hesitant to use other treatments for patients who were, whose oxygen saturations were dropping, because they were afraid of how it would spread the virus through the hospital, through to other healthcare providers, to other patients. And now we realize that some of those treatments are safe and effective. So there's treatment called high flow nasal cannula oxygen, where patients have just oxygen on, like if it was a regular nasal cannula going through their nose, but it's very high flow, humidified oxygen. And that helps quite a bit to prevent patients from needing to be put on a ventilator. And we're using that routinely now in all patients because we figured out how to do it in a safe way, in a way that's not spreading the virus. There's a tool called BiPAP that is a positive pressure mask that you wear that helps you breathe easier when you're hypoxic. And for the similar reasons, we didn't use that early on because we were worried that that was going to contaminate the room and spread the virus to healthcare providers. And we've figured out how to do that safely. There's also been a number of therapeutics that have been used more routinely now, including, you've all probably heard of the drug remdesivir. So that's being used routinely. There's patients being put on high dose steroids when they're hypoxic early on. That seems to prevent the need for a ventilator. So, the one positive thing with the second wave that we're seeing is that it seems that patients that come into the hospital, less of them are ending up on ventilators than during that first wave. And really the only thing that we can attribute that to at this point is better understanding of how to treat the disease, and then possibly the fact that it's a younger subset of patients that we're seeing infected now than that first wave. The first wave was heavily elderly patients, particularly nursing home patients. And this second wave seems to be more, younger patients in their 20s and 30s.
Thank you very much. The last question that I have, and I'm going to add a little part to this. Does hospital staff get priority for testing? And if so, how often do you guys get tested?
The hospital staff, the priority that we get is that the hospitalists at ECMC, and I think all the hospitals have a mechanism to do this. If a employee is sick with flu-like symptoms or possible COVID symptoms, there is a mechanism for them to get tested, often to get rapid tested with results within a day. And the reason for that is that we need our healthcare workforce to be able to return to work. So if we didn't have that available to the healthcare workers, then and everybody had to wait, for a routine test and wait for 5 days or 7 days for the results, or have to quarantine for 10 to 14 days, we would very quickly be in a situation where we did not have the healthcare staff in the hospitals to take care of patients, or at least we could end up there. So yes, there has been priority to testing healthcare workers. We are not routinely tested when we're asymptomatic. So there are no hospitals that I'm aware of that are screening their employees on a routine basis with COVID tests.
I'm going to ask, I think that's it in terms of questions that people had asked. I'm going to ask one last question, and then I think we'll be done for today. My question is, as public health students, as medical students, as community members, what is it that we can do to best support both emergency services and emergency departments as the potential for another lockdown occurs and this pandemic continues?
Well, I didn't mention this in my presentation, but one of the things I find very interesting about this whole pandemic is that March 15th was the first week that we had positive cases in Erie County. And that week there were 3 positive cases. And when that happened and, everything was shut down, I think we all remember those days of driving down the highway and it felt like, there was nobody else on the roads with us. And you'd go to the supermarket and the shelves were all empty and people were really trying to avoid any kind of contact with each other. Now we have a situation where we're having, 500 cases a day positive, and people are not really approaching or are not as concerned as they were early on in the pandemic. And I certainly don't want to return to those early days of that degree of isolation and social distancing. At the same time, I think that there is this pandemic fatigue where people just are not embracing the level of social distancing that I think is going to be required until we have a vaccine that's available to everybody. So that to me, I think is the one thing people could do a little bit more of, is a little bit more aggressive social distancing, particularly people getting together in groups indoors really should be avoided if possible.
Yeah, I would totally agree with that. I think what we can all do is take this moment in time very seriously. I think, in this time when, a lot of misinformation is out there and, there are still people who feel like, the efforts that are being required aren't real. I think making sure that when you talk about this, you talk about it with facts, and try to be someone who spreads, the truthful information as best you can. And I think personally taking it serious and demonstrating the things that people are talking about. I can tell you in our life, my daughter was playing hockey and her coach just got diagnosed positive and her team continues to practice. So I'm the mean mom that pulled my kid. And I think I made sure and shared with the team why I was doing that. And I think those are the things that are important, is to make sure that you're modeling the things that need to be happening right now, which are stressful and sad. But we need to limit, as best we can, the spread of the disease right now, or things, as Mike said about the graph that you would see now with the ED visit, like things will continue on that trajectory if we don't start to step in.
Well, thank you both very much for today. I feel like we can all walk away with a lot more information than stop sharing that. We can walk away with a lot more information. I want to thank everybody for joining us today. We are moving on to the second part of our lecture series on December 9th. We will be joined with the medical director of Planned Parenthood. They're going to be talking about reproductive telehealth, probably talking about some of those things that Dr. Manka talked about with telehealth and how widely it's now being used. But I want to thank you again, Dr. Manka, Dr. Lerner, for today. And like I told everyone at the beginning of this meeting, we will be posting the recording. Everyone will get an emailed version, and then it'll also be on our YouTube channel. So do you guys have anything left to say? All right, thank you very much, everybody, and I look forward to seeing you at the next meeting.
Thank you. Bye-bye.